Hey everyone, today we're going to be talking about respiratory infections. We're going to start with influenza and then go all the way through to pneumonia. Influenza is typically considered a seasonal influenza, but it can become a pandemic, as we all know right now. We have type 1 or type A, type B, and type C. As you can see, type A and B have H and N receptors. So think of them how we Hey everyone, today we're going to be talking about respiratory infections. We're going to start with influenza and work our way through to pneumonia. Our influenza family is type A, B, and C. Type A being the most common and the most dangerous. I want you to take note of the H and the N receptors on the virus. That's part of the naming process. So we have H1N1, H5N1. It causes inflammation of the upper respiratory tree and trachea. So it's a very upper respiratory infection. It's the complications of influenza that actually bring it to a lower respiratory infection. As we know, it's highly contagious through droplets and contact. And when people cough or sneeze or they are being intubated, sometimes it can be aerosolized. So I'm going to go over the process of how it comes into our body in a very, very simplified version, because that's really all you need to know. So the hemagglutinin, which is the H receptor, helps viruses to enter the epithelial cells in the upper respiratory tract. And then the neuraminidase helps the virus leave the cell and go into our circulatory system and into other cells. So here's our virus right here, and it comes in with the help of the hemagglutinin, and there's a whole bunch of stuff that happens in here that we don't really have to worry about, but there is RNA polymerase, and it becomes translated. And then this new virus that comes out is slightly different. So it's considered a new virus at this point. So our side effects when we have influenza is really our own body mechanisms trying to kill the virus itself. So we have inflammation of mucus and membrane and of mucous membranes. That brings all our WBCs and our cytokines and everything to try and stop the virus in its track. We have a runny nose. We have a cough. Those are all to get rid of the virus somehow by our excrements. A sore throat, that's just a normal side effect, unfortunately. We have a headache, typically because we become dehydrated. A high fever, again, is to try and kill off the virus. And then body aches, which are a side effect of high fever. Body aches are also have to do with very slight, talking very slight amounts of some lactic acid here, which tries to help kill the virus as well. So when we're talking about a normal virus, some of the meds that we want to take is, and these are subjective, they're dependent on the patient. So expectorants, which is a type of mucolytic for chest congestion. So that would be Mucinex, which breaks up the chest congestion to allow us to cough it out. Antipyretics for our fever and pain, so Tylenol. A decongestant for sinus congestion. Antihistamine for postnasal drip. Antitussives, which is a cough suppressant, but only if you have a non-productive cough. If you are coughing up phlegm and yucky stuff, we want that to happen. So then we would not want to give you an antitussive. And then mucolytics, which is something that RT does, and it thins secretions as well. So we also have some antivirals. So remember the N in on the virus itself, the neuraminidase. that we have those as inhibitors. So you know some of these. So the oseltamivir, so Tamiflu, that is given for at the very beginning of your onsets of signs and symptoms of the flu. And that's to stop the virus from breaking out of the host cell. So it helps prevent the spread through lungs. And so that specifically inhibits the N in the H and the N virus. So overall, and we have amantadines, damantines. And then we also have a category here, which includes amantadine and rimatidine. And these actually help prevent replication. However, these are only work for influenza A, and they replicate okay, so here we have our antivirals. We have the neuraminidase inhibitors for A and B. We know these from very well. One is Tamiflu, that these medications need to be given usually within 24 hours of the onset of your flu in order to help really decrease the signs and symptoms of the flu for you. It stops the virus from breaking out of the host cell and prevents the spread then through the lungs. And then we have another category here, which includes amantadine and rimatidine. This is for influenza A only, and it prevents replication. The problem is that the virus replicates itself so often and mutates, and so this amantadine is not usually used because because of the replication process. It doesn't work very well. So for the neuraminidase, this is the N in the H and the N receptors on the virus. And so remember, that helps the virus leave the cell. So this is going to inhibit that. Overall, these meds, all they do is they try to shorten the duration of the flu. It's not going to take it away. So we have two things that happen here with the influenza. One is called a genetic shift and one is called an antigenic shift. And with the okay, so with influenza, we want to talk about a couple things. We want to talk about genetic shift and antigenic shift. So genetic shift right here is when type A mutates its H and N glycoproteins. So during replication, okay, so influenza here, I want to talk about genetic shift and antigenic shift. And as you can see here, type A has those H and N glycoproteins. And then during replication, what happens is it splits apart, and some are more similar and some might be a little bit different. So say this is the mom and these are the two kids. These are the replications. So as you can see, the H, this is an HY, this is an NY, this is an HX, this is an NX. Think of it as like fraternal twins. Okay, it's going to get rid of two. This is very simplified. Now, the person who comes in contact, maybe they have immunity to this type A right here, but when they become in contact with this new mutated virus, they might have some immunity to this fraternal twin, and so it doesn't affect them. But this particular one is the other twin is slightly different, and so then all of a sudden they'll get the flu. So this can happen year after year, or even in the same year. So some people say, I got the flu shot and it didn't work for me. Well, the flu mutates, and so it could be another mutated strain that hits the patient. Or they could get the flu from this particular twin right here, and then 3 months down the line, they're still compromised, and then all of a sudden they become in contact with this second strain of flu. And so that's what happens. The antigenic shift. So this is where we come into more of the pandemic. So viruses from animals suddenly change to also infect humans. So say this is a pig cell right here, and humans contact the pig, so they might get the virus from the pig might get the virus from the person, but it doesn't bother the pig because it doesn't match. And then they get an infection from another pig, and it comes into the cell. Okay, so then inside with our RNA polymerase and everything, it conjoins and it brings together a brand new virus. This is where we get our SARS and our MERS and our COVID from. Okay, this brand new virus. So it's got the new H glycoproteins and the new N glycoproteins. So we have no protection from it. And even with the general flu, we can spread this very rapidly, which normally isn't a problem because we have our immunizations to the flu, and so it protects us from maybe our normal and maybe we might get a little bit sick, that's all. But in this particular case, we have no immunity, and some are extremely virulent and some are not. So let's take a look at some of our pandemic flus. So we have had H1N1 in 2009. And to put it into perspective, in the US alone, 61 million people were infected and 12,000 deaths. Our H1N1 now, because we have a vaccine for it, that is actually included in our seasonal flu shot. So when you get your seasonal flu shot, you actually also get H1N1 included in that. There's another strain called H5N1. We have a vaccine for that, but it's stockpiled for future use in case it comes into play. And chances are that's what's going to happen with the COVID once we get an immunization. Either they will give it to us with seasonal flu shot, or it'll be stockpiled for later use. This is a picture here. So the Spanish flu, a little bit different, but the Spanish flu killed 3% of the population. No vaccines were available, but remember, there really wasn't in 1918. There wasn't the transportation that we have here, so we have a much higher incidence of spreading the vaccine itself due to airplane transportation, traveling all over the place. Okay, so I know we talked about this in class, but things have changed. So I have a couple things for you here, and they're really just highlights. So just so that you know and you are educated on this, the coronavirus is a term for a large set of viruses. So MERS and SARS, for example, are part of the coronavirus family. COVID-19 came from coronavirus 2019. And then they saw a similarity with SARS. And so the new name for COVID-19, the real name, is actually SARS-CoV-2. Okay. So because it's kind of a mutated between, they're very similar. They're different, but they're very similar. Even with no symptoms, just like the regular flu, you can still be contagious. And patients that do get exacerbated side effects from any type of flu, including this one, can deteriorate very rapidly. So some of the problems that we deal with, because really we're just dealing with symptom management. So one of the issues is they get pneumonia. So when that virus spreads, remember it spreads from one alveoli to the other if there's no stopping of the spread. And so they're going to get a pneumonia, very bad pneumonia, hypoxic respiratory failure, ARDS, sepsis, septic shock. They can get cardiomyopathy because their blood is working overload and their heart rate is up and their blood pressure is up in the initial stages, and so it puts pressure on the heart. So that can cause arrhythmias, and then it can also cause acute kidney injury. And you'll be learning about a lot of this next semester. So ARDS is acute respiratory distress syndrome. The ICU, when patients are taken to the ICU and they're put on a ventilator, what they're showing right now is the mortality rate for COVID is 39 to 72%. Some of that has to do with the fact that they're on a ventilators. So I got some information for you. So from the CDC, this is very interesting. ACE inhibitors, ARBs, these are all cardiac medications. And remember how they're saying that cardiac patients are at higher risk. So these are ACE inhibitors. So they may increase ACE. So COVID may increase angiotensin converting enzyme. Okay. The SARS uses ACE receptors to enter the host. Okay, so per the CDC, this is some information from them. ACE inhibitors and ARBs. They actually, those medications, which are for cardiac patients, remember they say cardiac patients are at higher risk, may increase the risk of COVID. So what they do is they increase the expression of ACE2. And we haven't really talked about ACE2, but it's just a different angiotensin converting enzyme. So if they increase the expression of ACE2, and what they're seeing is that COVID uses the ACE2 receptors to enter the host cell. Now, this doesn't mean that patients on ACE and ARBs should stop their medication, but it just is some information that we know that maybe they can use in the future. NSAIDs, we've heard about NSAIDs saying that they can worsen COVID, but this is just a hypothesis. Corticosteroids, which we might normally use to decrease the inflammation in the lungs, can actually prolong viral replication, which it then increases the need for a ventilator, which is bad because if we need a ventilator, then our mortality rate goes up. Oops. So our treatment really is supportive per the World Health Organization recommendations. And I'm going to go into that a little bit right now. I'm actually going to give you upload a form on the World Health Organization recommendations. Okay, so this is a summary of some of the World Health Organization recommendations for COVID right now. So antipyretics, so Tylenol to keep the fever down. Our oxygen therapy target should be greater than 90%. Okay, so 91% is perfectly fine. We want to do conservative fluid management. Now, what I'm going to tell you for some of this, for some of these highlights is that it seems to be opposite of what we normally do, and they're finding this on an ongoing basis. So this lecture, maybe in a couple of weeks, might be slightly different because of the information that they're finding. So normally, if we have someone in our ARDS, or if they're in septic shock, what we're going to do is we're going to flood them with fluids, like so many fluids. We're going to give them like 3 to 6 liters, maybe. Okay, and it's weight based. And so what they're finding with COVID is that the aggressive fluid resuscitation actually worsens the oxygenation. So when you talk about pneumonia, you talk about fluid buildup in the lungs, and typically fluid with a regular pneumonia will help thin the secretions, will help with movement. We still have to watch for fluid overload in the lungs, but with COVID, it just worsens the fluid in the lungs, period. And so then we receive worse oxygenation for our patients. They are still recommending that the initial assessment on a septic patient to the hospital be given antimicrobials within 1 hour of the sepsis identification, which would be considered a lactic acid. And then just in case it's not COVID. So ARDS, they're recommended severe hypoxic respiratory failure. So they are actually recommending 2 things. They're recommending prone ventilation for 12 to 16 hours per day. What that means is that the patients are on their belly. We do this now for some patients that have severe secretions in their lungs, and it actually helps with taking the secretions out of the lungs. So 12 to 16 hours per day. With intubation, using a ventilator, they are suggesting low tidal volumes and low inspiratory pressure. So with this right now, they're finding that that is minimalizing the mortality rate. Okay, so using low volume and low pressure. So don't increase the pressure just because their oxygenation is lower. Try other things. Septic shock. So septic shock, we will, if someone's blood pressure is starting to drop, we'll typically give them fluid, maybe a 250 to 500 milliliter fluid in the first, for 15 to 30 minutes after we realize what's going on. And normally that gives you a little bump in the blood pressure. And if it does, then that's great. Then they'll probably continue the septic shock protocol. But if there is no response from the patient, if the patient's blood pressure does not increase, then that may be a sign that it's detrimental. So in other words, no fluid boluses. So then they would actually need to go straight to vasopressors. And absolutely no hypotonic fluid. So they're not really concerned right now then about cellular dehydration, right? Which is really unusual. So this is kind of backwards of what we would normally do. And then adjunct therapy, again, no corticosteroids. There does not seem to be any benefit and delays the viral clearing, and it can also cause avascular necrosis. Some research I just want to share with you. I'm not going to go over this, but this is an immunomodulator, which is the new and upcoming medications that we use for cancer. And you can just take a look over this yourselves. These are just medications that are currently on research. So now let's take a look at pneumonia. So let's just go straight back to regular seasonal influenza, okay? When we're talking about this, because COVID is this kind of a special entity. So pneumonia is triggered by an infectious agent, bacterial, viral, or fungal. And many times it is a progression of the flu itself, or from aspiration. We get aspiration pneumonia. And typically, if we have aspiration, our cough reflexes, we cough it up and everything is okay. Okay, so now let's talk about pneumonia. And what I want you to do is kind of backtrack a little bit, and let's just talk about seasonal influenza when we're talking about pneumonia. We're not going to be talking about COVID here. So it's triggered by an infectious agent, either bacterial, viral, or fungal. And it can also be a progression from the influenza or from aspiration, as you know. So influenza is a pretty big cause of pneumonia, but any type of bacterial or fungal infection that we inhale can cause the inflammatory response and cause perfusion of the bacteria or viral in the lungs, causing pneumonia. So pneumonia really is what happened, kind of the end stages here. It really is an increase in fluid in the lungs. And so that's why you hear so many crackles and expiratory and inspiratory wheezing when you listen to a patient's lungs that have a patient who has pneumonia. So inflammatory response, again, from that bacteria, or we're going to talk about viral pneumonia, for example. So inflammatory response in the interstitial spaces, the alveoli become inflamed, the bronchioles become inflamed. The inflammation takes away some of that ciliary movement, so it can't, things get exudate and everything gets blocked. It can't move the exudate or pus out of the alveoli or out of the tubules. So the immune response for this really is WPCs for the infection. So they, kind of accumulate in the alveoli. Edema, exudate develops, which are with exudate develops with RBCs. Okay, we're going to start. Okay, guys, so let's talk about pneumonia. And we're not going to talk about COVID here. We're just going to talk about pneumonia in general. And whether it's bacterial, viral, or fungal, the process is very similar. But it can also be caused by influenza and aspiration. Bacterial, influenza, and aspiration are probably the three most common. And so let's say we have, with influenza, we inhale, we get influenza, and okay, guys, let's talk about pneumonia. So it's triggered by an infectious agent, whether that be bacterial, viral, or fungi, or it can be a progression from other illnesses, such as influenza or even from aspiration. Whichever organism it is, it colonizes in the bronchioles and then also in the alveoli. The inflammatory response happens in the alveoli and bronchioles and interstitial spaces. When that happens, the immune response is WBCs to the infection, edema occurs, exudate develops within the bronchial tubules and the alveoli itself. That develops with RBCs, leukocytes, and fibrin filling the alveoli. So we've got a really clogged alveoli that cannot expand, contract, and it cannot even take the oxygen and put it into our system and then take our CO2 out because it's clogged. This is considered then a ventilation perfusion problem if we can't get oxygen into our cells and out of and CO2 out. So the infection can also move into the bloodstream, which is sepsis. Empyema can also collect, so this is pus. So pus can develop anywhere in here into the lung cavity. It typically will come down and sit in a spot at the lower because it is heavy, but it can also pus can also form and get caught in the bronchioles themselves. Fibrin and edema from the inflammation stiffens the lungs, stiffens the alveoli, stiffens the bronchial tubes, which of course then causes a separate response. So continued inflammation and stiffening of the bronchioles and alveoli will possibly lead to something called fibrosis if this is a repeated offense year after year after year. The alveoli as well just can collapse just because they're so overworked and they're full of fluid, so they can collapse. And when they do collapse, it's called atelectasis. So you'll see that on some of the your doctor's notes that they have atelectasis, and that's when a portion can collapse. Okay, if we have, looking at this lung up here, if we had a section right here that was full of mucus in this bronchial tree, no oxygen or air would be coming into these alveoli, so they might collapse. Okay. There's some different pneumonia categories. I just wanted to show you that just for visual. There's the bronchopneumonia, which really takes over all of the lungs. So everything, because you can have like pneumonia in the top, you can have it in the bottom, it just depends. And then you can see here that some areas can become consolidated. So this green might be exudate, it might be fluid because we build up a lot of fluid with pneumonia in our lungs, and so the fluid has leaked out here and is causing a compression on the lung. So again, when you think of pneumonia, think of infection and think of fluid buildup in the lung. So we have some medications. I tried to match them up with the side effects, but take it with a grain of salt. We've got a productive cough, so then we might want to use an expectorant. We have fever, so an antipyretic, shortness of breath. We can give asthma meds unless it's a fungal pneumonia. If it is a fungal pneumonia, we do not give asthma meds, especially we do not give corticosteroids because the steroids help increase blood sugars and sugar feeds fungals. Fatigue, they definitely will be lacking in oxygen, so they will need oxygen therapy. But you follow the doctor's orders depending on what level of oxygen they want you to keep the oxygen at. Confusion also from lack of oxygen, so we might be giving oxygen therapy. We'd be giving antibiotics, antifungals, antivirals, depending on what the cause of the pneumonia was. Pain medication, this is painful. It's pain when your chest expands. When you expand and contract your chest, it hurts. And so it hurts to breathe. Antitussives I have at the bottom because antitussives will suppress cough. We only want that if it is a non-productive cough. So preferably we want them to have a productive cough, but if it is non-productive, even with our interventions, then we can go ahead and give them antitussives. This is just a list of the common antibiotics for a bacterial infection that we might use for pneumonia. So we have our cephalosporins, our macrolides, the fluoroquinolones, penicillins, tetracyclines, and then lastly, vancomycin.